Hello, everybody, and I want to first of all thank Pramila and the Brain Foundation for putting this all together. And as I hear more and more of the lectures, the fact that we have a multidisciplinary panel of experts with increasingly evident overlap in our interests really makes me all the more confident that with our combined input, we're going to come up with some very interesting findings. I wanted to speak about the a specific type of patient that that I have. It's a very common patient. A patient with autism and autism-associated enterocolitis, who, upon treatment of their inflammatory bowel disease that we see on biopsy or a capsule endoscopy or regular endoscopy, on treatment of that, we can get rid of their presenting symptoms of diarrhea, constipation, pain, etc. But a lingering problem in a significant minority tends to be chronic constipation, and it's a hypomotility constipation, the kind that Dr. Gershon was speaking about. And I want to speak about those patients and what we found related to them, and how what our Dr. Walker, Steve Walker at Wake Forest, and the other authors you see here, our findings really do overlap with many of what Dr. Gershon was saying. I have no relevant disclosures. Definition of autism, we all know. So the background about what I want to speak about. Children with ASD who have comorbid chronic GI symptoms. And these are symptoms that could be diarrhea, constipation, or alternating diarrhea, constipation, abdominal pain, abdominal distension, failure to thrive, difficulty passing stool that is not overly hard, vomiting, reflux, and many other symptoms that I'm probably forgetting to mention, but that's the patient symptom population I'm speaking about. So you approach those patients the same way you would any other patient, as Dr. Balzola had said, and you do initially a non-invasive GI workup to find out what the etiology of these symptoms are, and more often than not, you do not find a diagnosis, and they are subject to an upper endoscopy and a colonoscopy and often a capsule endoscopy. And when they are, what we find more often than not, over 80% of the time, is, and this is all published, is a unique pattern of intestinal inflammation. And we're going to go through those quickly. And because it's unique, it's not exactly like Crohn's disease or ulcerative colitis or lymphocytic colitis or microscopic colitis or enteritis, but there is definite overlap. So because of that, we've chosen to give it the label as autism-associated enterocolitis. When you have a patient like that, and you treat them with medications that we use in conventional inflammatory bowel disease. So what happens with those patients? So first of all, to further describe those patients pretty quickly, on the left column, the two photographs are the endoscopic view of the colon, and you see that there's a lack of vascular markings, and there's a lower left is some patchy erythema. The mid upper is a terminal ileum, and you see some neutrophilic infiltration of the crypt. So it's a classic cryptitis, and this here you see is mildly active chronic active inflammatory infiltrate. And again, this is a lower power view of the colon, and here you see a localized area of focal chronic inflammation with the bifid crypt. And here, the capsule endoscopy, which I found over the years to be the most informative study of all, you find classic aphthous ulcerations. You see it over here, you see the ulcer, and you see over here you can see some of the exudate, and you see it over here as well. Typically, liquid stool also likes to cover ulcerations, and sometimes it's difficult to tell whether this is in fact covering stool or whether it's exudate. The lower photograph actually is more clear that is an exudative aphthous ulceration. So these are the types of patients that we're speaking about. That's what we find on routine endoscopy, colonoscopy, capsule endoscopy. We know that they, when you subject the colonic biopsies to immunostaining, you find that there is a preponderance of CD8 here in the upper left photograph, micrograph. You find this is normal colon, meaning a non-autistic child who underwent colonoscopy, had no diagnosis, and these light brown areas are CD8 cells. So there is some low level of CD8 presence in the colonic mucosa and submucosa. In the lower left, in photograph B, you find that the CD8 concentration is much higher. And the interesting thing is that on normal H&E staining, you wouldn't necessarily see this. So unless you subject these biopsies to immunostaining or immunohistochemistry, you would not find that. And this is the colitis that we speak about. And because you don't see it on H&E staining, and you see it really only upon immunostaining, in this particular pattern, it's pericryptal. So again, this is one more reason why we feel confident in giving it the name autism-associated enterocolitis. Here on the lower part of the screen, you find that the CD3 and CD8 cells, they fall somewhere between what you see in Crohn's disease and ulcerative colitis, but they're clearly above normal control subjects and normal children, meaning neurotypical children who have just lymphoid hyperplasia but no inflammation. When we analyze our biopsies further, what Dr. Walker and our team at Wake Forest found, this slide demonstrates terminal ileum. And what it shows is a PCA analysis. And then for those of you familiar with it, great. If you're not familiar with it, I'm just going to move on because it may take a bit too long. But it's a way of taking a very large amount of data and compressing it into a very, very small area in three-dimensional space. So here we're looking at messenger RNA transcripts. And there are tens of thousands of them in a given individual. And what you see here, each dot is one individual, and their messenger RNA is being compressed into one dot, and it's being shown to us on a graphic interface that's three-dimensional. And actually, you're able to rotate this cube. And the purpose of this really is to show that a transcriptome analysis of patients with purple ASD, green healthy controls, blue Crohn's disease, and yellow/silver ulcerative colitis, they do fall out in different zones. And what's interesting is that you have the Crohn's patients are really the blue or admixing primarily with the autistic kids, and primarily meaning statistically significant. Both the Crohn's and the autistic patients are far apart from the normal healthy children. The ulcerative colitis patients are also admixed statistically and in space with the ASD colitis, this is an enteritis patient. And this is further evidence that the patients who are showing very minimal, if any, inflammatory infiltrate on H&E staining are in fact manifesting an inflammatory bowel disease that's akin to Crohn's and ulcerative colitis, yet is very different. So when faced with that patient, I typically treat them as I would any other inflammatory bowel disease. I like to start off with an induction course of corticosteroids, followed by maintenance 5-ASAs such as sulfasalazine or Pentasa. There are other types of ASAs. The list is quite long. And patients, as is the case in Crohn's disease, patients who respond adequately, you leave on the 5-ASA. And the patients who do not respond adequately in terms of their GI symptoms are placed on immunomodulators such as methotrexate or mercaptopurine or biologic agents. And we're going to discuss those biologic agents and immunomodulators and the other medications I typically use later on today and next week as well. But these patients are treated. Wrong button. How do these patients respond when we treat them that way? So this is a paper that we published in 2019, April of 2019, which seems like it was a lifetime ago. And what we found was that when these patients were treated for their inflammatory bowel disease with routine medications that we use for conventional IBD, we found improvement or resolution in their presenting GI symptoms, their pain, their diarrhea, their constipation, their abdominal distension, their growth, in 75 to 80% of patients by 12 months of age. So their lives were markedly improved. What was also quite interesting and surprising was that concurrent with the improvement of their presenting GI symptoms, we also saw cognitive and behavioral progress that was at an accelerated rate to what we would expect simply from feeling better. When somebody feels better, they'll of course function better, whether they're neurotypical or autistic or anything else. But the degree of cognitive and behavioral acceleration so rapidly exceeded that which was predicted by any of their therapists or of their parents. And that, of course, makes one wonder whether cognitive and behavioral deficits in ASD in particular are in fact related to active GI disease. But this was our finding. Now, the problem that I had was that these patients are GI responders. By GI responders, meaning that their pain, their diarrhea, their distension, that all went away. But in 30% of them, the significant minority, they had persistent or recurring right-sided colonic fecal loading that required repeated bowel cleanouts, often repeated monthly scheduled bowel cleanouts with irritant, stimulant laxatives, not osmotic laxatives. Those tend not to work. Whereas the majority, approximately 70% of patients, when we remedied their other GI symptoms, the pain, the diarrhea, we also remedied their constipation. And the question that we had was, why is it that constipation was such an enduring problem in such a large minority of the patients? And now this was not a constipation of overly hard stool. This was the soft stool constipation. This was the fecal loading that we speak about with ASD. This was difficulty pushing, straining, inability to get stool out, that when the stool did emerge, it was normal looking stool or even semi-formed. It certainly wasn't overly formed, and you wonder why the patient had such difficulty getting it out. And that brings you to, of course, questions of whether it's going to be neurogenic or myogenic. We'll come to that in a second, but this is a typical x-ray of one of those kids. And you see over here that the right colon is loaded and also distended with stool, but the transverse and descending colon and even the rectum doesn't have any significant stool in it. And this is the typical radiograph that we see in a patient like this. So for example, clinically, when I'm treating a patient, they go through an induction course of corticosteroids, life is great, their pain is gone. Then in a month or two, they start having terrible pain, almost invariably. When I ask the question, has the stool frequency decreased? The answer is yes. We do an x-ray, and this is the x-ray that we see. And the question is, why is that? Why do 30% of patients who respond in all other areas of GI symptoms, why do they persist in having this chronic hypomotility, soft stool, right-sided predominant constipation? And by the way, I should add that having it on the right side, right-sided fecal loading is an unusual, very unusual pattern of constipation. Constipation typically takes two forms. Either it's pancolonic throughout the entire colon, or it's left-sided, which is a much more typical constipation. But to have a right-sided predominant constipation where the majority of a disease, of a constipating disease, presents with right-sided hypomotility, we didn't find any other disease that has that description, yet that is the distinguishing factor in this disease. So quite interesting. So what are the hypotheses that we have? Well, first hypothesis was that there may be a right-sided localized neurogenic or myogenic inflammatory pathology with consequent localized hypomotility, or there could be a right-sided localized metabolic pathology independent from inflammation, perhaps from dysbiosis, perhaps from an altered microbiome that's localized in the ascending colon. And that would cause a consequent localized hypomotility through pathways perhaps that are serotoninergic. So we designed the study, and I may have to move through the study a bit fast, but certainly it's available. It was the paper we showed you before. With a retrospective comparison of right-sided biopsies, we decided, we're going to take the biopsies that are obtained at colonoscopy of the right side, the ascending colon and or the cecum of the patients who were slow responders, who had that recurring or persistent right-sided constipation. Take their right-sided mucosal biopsies and compare them to the right-sided biopsies of the patients who did not have any chronic constipation after their treatment for inflammatory bowel disease. We did a whole genome RNA sequencing for both of these groups. And again, to run through this a bit quickly, what we found when we did that was we had 68 gene transcripts that had a very highly, that were much more highly expressed in one group versus the other. And so we created two clusters, the cluster of those 68 versus those who did not have that. And then we reclassified them based upon those clusters. So in cluster one, based upon the 68 subsets, in cluster one ended up having 12 fast responders and 4 slow responders. Cluster two has 16 slow and 3 fast. So again, so what this shows is that statistically, this messenger RNA clustering is in fact an indicator. It's a rough indicator of these two phenotypically responding groups to the same therapy for IBD. And then we did, and again, a differential expression analysis. We repeated that upon these two clusters defined in this way. And there we found there were almost 3,000 messenger RNAs that had a high level of significance as far as their differential, expression. And on those, we conducted, number one, a pathway analysis to see which pathways are associated with those messenger RNAs, because the messenger RNAs are a hint what the genes of those biopsies of slow and fast responders in that right colon, what those genes are expressing, may very well be telling us that there are pathways. They may be representative of pathways that are responsible, perhaps, for the etiology. This methodology, it's almost impossible to determine with 100% accuracy that those are, in fact, the biological mechanisms responsible for the specific phenotype you're looking for, but it certainly gives you a clue as to where you should begin looking. So on the one hand, we subjected these transcripts to pathway analysis. On the other hand, we also used the lasso, which is a statistical method at finding out, is there a biomarker or biomarkers that can highly predict from the outset whether a patient is going to be a slow or fast responder. So our data generated this heat map. Again, those of you familiar with, many of you I'm sure are familiar with this heat map. Basically, each of the column is a patient, and each of the rows are the significant messenger RNAs. And the important part is to look at the dendrogram up on top. This dendrogram, the shorter the bars are, as many of you may know, the shorter the bars are, the more similar the patients, each column is a patient. Shorter the columns are, the more, I'm sorry, each column is one of those 68 individual RNAs. The shorter the columns are, the more relevant those 68 are to each other. Further apart they are, the less relevant. And the dendrogram actually breaks these groups down into two groups, cluster 1 and cluster 2. And to our amazement, really, we found that using messenger RNA transcript technology, we found that the fast responders do, in fact, this is a pictorial representation of how the fast responders cluster together. There are exceptions, so it isn't 100% perfect. But the slow responders, those who remained hypomotile despite having resolution of the classic inflammatory pathology, those patients clustered together as well. So the next step was to say, okay, so those transcripts, which pathways are they statistically indicative of? And this is where what Dr. Gershon was saying really impressed me. The fast responder group had a number of pathways that really involved cell signaling, inflammatory pathways, Th2 activation, Th2 pathways, innate and adaptive immune activity. So these are rough. These are not specific pathways, but these are rough pathways that would need further analysis, but it gives you a clue as to where you should begin looking. The fact the fast responders had so many pathways involved that were inflammatory, and they're the ones that responded to the inflammatory, anti-inflammatory medication in their entirety, whereas the slow responders, there we saw a predominance of serotonin, dopamine, nicotine pathways. These are all, of course, involved with motility and cholinergic activity of the bowel. The fact that there are abnormalities in those pathways, and of course there are other pathways as well, but we have clearly two separate groups based upon their phenotypical presentation, response to anti-inflammatory medication, and the resulting pathways that jump out at you are exactly what we see clinically when we treat the patients with a lingering poor motility. The last slide I want to show is as far as a biomarker. So we asked the question, is there a transcript that reliably predicts that a patient will either be a slow or fast responder, but that a patient will have this lingering problem of poor motility? And the answer was yes. It was a single long non-coding RNA transcript that with over 90% specificity and was able to predict a slow responder from a fast responder. So this was very interesting to us. The reason why this clinically is important to a clinician is because when you get this kind of a biomarker, assuming we can replicate it in subsequent studies, if I would know from the outset, looking at that right colonic biopsy, that this patient's going to be a slow responder, then I would be much more likely to include at the very beginning, not just anti-inflammatory medications, but also medications that would increase motility, such as the 5-HT4 agonists, such as other regimens of laxatives, such as mitochondrial support medications that we know are also involved in the motility of the bowel. So, this was our paper we published, and I wanted to review this with you. I'm hoping that you've gained from it. And Dr. Gershon, I see that you're actually on right now. And there was a question that I had for you after your lecture. When you spoke about prucalopride being a 5-HT4 agonist, and you were looking at that, I was wondering, back in the old days when we used cisapride in the, 20 years ago, which was also a 5-HT4 agonist, do we find, or did you work with cisapride at the same level of analysis as you have with prucalopride? You may not have had the technology available back 20 years ago that we have now, but I was wondering, would cisapride be an agent that we can use, and would that bypass the SERT mechanism as the prucalopride does?
Cisapride would exactly do that. The only problem with cisapride is that it is in contrast to prucalopride, a very dirty drug. It has many other functions besides its one action. It's a 5-HT4 agonist. It's a 5-HT3 antagonist. And worse than that, it's active at the ATP-dependent potassium channel and has cardiac toxicity. So it was taken off the market for that reason. There's no reason to use cisapride. Prucalopride is now licensed and is available in the US for treatment of IBS. It's a perfectly good drug, and it's a pure agonist at the 5-HT4 receptor.
It's pure, not dirty. Okay. Thank you.
Yeah, it's not a dirty drug.
Thank you.
And I should have mentioned it also, these mice that we work with that have the SERT mutation, super SERT mice, they have features in their behavior that are similar to autism. That is, they don't socialize with other mice, and they have repetitive behaviors. And their behavioral problems also go away when you give them prucalopride. And both for the gut and for the behavior, what's particularly striking is that when you give the prucalopride during development, the animals are okay for the rest of their lives. They don't get it back.
Interesting. Very interesting.
Dr. Krigsman, we need to finish up.
Okay. That's it. This is my last slide. Oh, I'm sorry. It's not my last slide. Okay. Okay, so very quickly. So number one, differential gene expression analysis in the cecal and ascending colon from mucosal-derived biopsies does in fact identify clinically relevant subgroups of patients, fast and slow responders. The fast responders demonstrate a dominant theme of upregulation of cellular and humoral immune responses, cytokine signaling. The slow responders, their dominant theme as far as their pathway analysis is one of dysregulated degradation pathways and mitochondrial dysfunction. And we hypothesize that because the fast responders reveal a primary theme of upregulation of inflammation, that is their theme, treating those patients with anti-inflammatories, immune suppressants, those patients, all of their GI symptoms, even constipation, resolves. However, slow responders, if the primary theme of their transcripts suggests a metabolic or mitochondrial dysfunction, then we would not expect that particular symptom of hypomotility to improve with anti-inflammatory therapy. And of course, we identified a biomarker that appears to predict slow responders with a very high sensitivity and specificity. And interesting, it's a long non-coding RNA, so it has no known function, which makes it even more interesting. So it's clinically relevant because when we see a pattern of right-sided fecal loading, and we're aware of this, we can be more aggressive as far as what kind of laxatives to give patients, and also what kind of other prokinetic agents may benefit them. And I think I will end over here. Thank you all very much.
Thanks very much, Dr. Krigsman. We do have one other question for you. Your data demonstrates an immune response takes place in the intestinal tract. What do you think is the trigger? A food allergen or something else?
There seems to be an early trigger early in life. We don't know what that trigger is, but we do know that subsequent to that early trigger, there are multiple other triggers. So for example, once this disease is already in progress, Dr. Giannucci has shown that dietary antigens will further accentuate that inflammatory process and further increase the level of pro-inflammatory cytokines. But what the absolute upstream problem is, we don't know.